So good morning, everybody. My name is Megan Williams, and I am the Director of Support Services at Alzheimer Group. January is Alzheimer's Awareness Month. This year, AGI features a series of lectures to raise awareness and demystify the misconceptions of Alzheimer's and other forms of dementia. AGI supports people living with dementia and their families. Our services include online activities, in-person activities when we can, individual and family counseling, education, workshops and lectures, and support groups for caregivers. Today's lecture is made possible by the generous support of the Lasner Learning Center. AGI is a charitable organization, and we rely on the support of donations. This is a free lecture, but you are welcome to donate at any time by calling us or visiting our website. Today's lecture, everybody will be on mute, and you can use a Q&A or the chat function to ask questions. At the end of the presentation, either Nin, our outreach coordinator, or myself, we will be reading questions to Dr. Bergman. For today's webinar, we have the privilege to present Dr. Howard Bergman, who will be speaking about the hope and challenges in diagnosis, treatment, and care of persons living with dementia. Dr. Howard Bergman is the chair of the Department of Family Medicine, professor of family medicine and oncology, and the first Dr. Joseph Kaufman Professor of Geriatric Medicine at McGill University. The main thrust of Dr. Bergman's work has been linked to research with policy change in fields of aging, chronic disease, and frailty, and the promotion of primary care. His work on integrated care for very frail older persons is recognized internationally in both academic and government circles. He is now working with the Ministry of Health in implementation of the Quebec Alzheimer Plan. Dr. Bergman, the floor is yours.
Thank you. Thank you very much. Hello, everybody. I can't see you, but I think you're there. I'm going to now share my screen so you could see my slides. Let's see if I do this properly. How's that? Megan, my screen is shared?
Yeah, that's great. That's great.
Okay.
Yeah, go ahead.
So thank you very much for this invitation. I just want to make a quick correction on my title. I was chair of Department of Family Medicine up until November 2019. I'm now, as you can see from the title, Assistant Dean, International Affairs in the Faculty of Medicine, Health Sciences at McGill. So it's a real pleasure to be able to speak to you, and I'm going to try and limit my time to about 35, 40 minutes, so to give enough time for questions and discussions with you. So first of all, I have no financial or business conflicts to declare, but you can see, and I ask you, by the way, to read the slides, because I'm not going to read every line on the slides. I had the privilege and honor of being the author of the Quebec Alzheimer Plan, and I co-lead a research team on the Organization of Health Services for Alzheimer's, the ROSA research team, author of the Canadian Academy of Health Sciences expert panel report on dementia, on the Canadian Dementia Strategy, and now a member of the World Dementia Council, and work with the ministry in the implementation of the Quebec Alzheimer Plan. So many of you know Charles Dickens. I think this quotation from Dickens represents a lot of how we feel at the present time: the best of times, the worst of times, age of wisdom, age of foolishness, spring of hope, winter of despair. But you know, as difficult as the time that we're in, I think there's a lot of reasons to be hopeful and optimistic about the future, including about the future of dementia and Alzheimer care. So memory is always a big issue, right? So this is from this magazine, How Much Memory Do We Need? They weren't talking about our own memories, they were talking about our computer, but we're always talking about memory now. Do we have enough memory? is the computer going to freeze? Are we going to freeze? So I thought I'd start off with this case report of this gentleman in 1981 who was age 70, high functioning at work, seemed to have some changes following general anesthesia. And then at the age of 75, seemed to be decompensating under stress. He retired at the age of 78. Then people started seeing progressive memory loss. And in 1994, diagnosis of Alzheimer's disease. This is sort of a typical pathway that we see. And some of you might recognize that RR is in fact Ronald Reagan. I was never a great fan of Ronald Reagan as the president, but I admire very much the fact that the family contributed to making this public and to supporting the development of care around Alzheimer's disease. But that whole pathway is very, very typical. So this slide, and please read it, I'm not going to read each line. This slide shows that in many ways, there are no changes or even improvement with age in terms of cognitive function. But they're all normal changes with aging. There are declines, and those of you who are elderly, or you will notice that naming and names, recalling names of people becomes more difficult for all of us. And sometimes it doesn't start when you're age 65, it starts even earlier than that. So there are changes, there are declines that are normal, but there are areas that don't change. In fact, judgment and semantic memory may in fact improve. So what is dementia? I presume that most of you have thought about this, and if you're at this lecture, you probably know better, but I thought just a good idea to put this forward is, so the definition of dementia, there's variations with the new DSMs, but basically impairment of memory, impairment in at least one other area of cognitive function like language, judgment, executive function, etc., and impairment sufficient to interfere with function and activities of daily living. Those are the key elements of dementia, diagnosed from a clinical point of view. There's also this entity called mild cognitive impairment, where there is objective impairment in the cognitive testing, but all abilities to carry out daily living, activities of daily living in an independent way are maintained. So it does not meet the criteria for dementia. So this is, please try and follow this. This is, I think, a schema that I find useful in understanding. So we have the supernormal, and whoever they are, I haven't seen many of them. There's absolutely no deterioration from young. I'm not sure they really exist, but it's there. And then the age consistent loss average, people who have memory change, which is the average for their age. And that's this whole group we call normal aging. And then abnormal aging, we have people who suffer from dementia, people who have mild cognitive impairment, which unfortunately is a risk factor, an important risk factor for moving toward beginning of dementia in older people with MCI. And so any decline is also exacerbated by depression, medication, inappropriate medication, medical illness, neurological illnesses. So this is a fairly good diagram to understand the dynamic aspect of dementia. When we're evaluating cognitive decline in the clinical setting, we do it in different ways. The importance of the speaking to the patient, the person who has cognitive decline, speaking to the family, doing mental status tests, doing a physical neurological exam, imaging, lab tests, functional status, understand their functional status, and of course, understanding the context and situation of the caregiver. And this is an extremely important point that we still have trouble getting it right. But so evaluating cognitive decline is a complex evaluation that is part cognitive evaluation, part physical exam, part imaging, lab test, etc., and functional status. The earliest symptoms of cognitive decline, I thought I'd put this, the presentation can be very variable. Memory loss is the most common. Sometimes languages, word finding difficulty. Sometimes begins with orientation, getting lost. We see loss of judgment, insight, and personality change or social withdrawal, loss of confidence. These and the beginnings are often very, very subtle in the earliest symptoms of cognitive decline of people who are developing dementia. So in terms of the clinical approach, once we've gone through the evaluation, we work in disclosing the diagnosis, and this is an important point. You know, 10 years ago, the trend was to not tell the person that they had Alzheimer's disease. A bit like cancer 30, 40 years ago. Oh, don't tell my mother she has cancer. More and more now, not more and more, now we feel that the person with the diagnosis needs to be treated with respect, dignity, autonomy, and has the right to know the diagnosis. Of course, has to be given in a caring, respectful way. We need to provide information on the disease, start financial planning, discuss driving, safety at home, and of course, again, the health of the caregivers. So this is once the diagnosis is made. And how do we treat it? Right now, we have symptomatic medication. In other words, it doesn't treat the disease. It's a bit like aspirin for a headache. It doesn't treat the underlying reason you have a headache, but it relieves you of the symptoms. And you probably know these medications as well as I do. You know, what I like to say to my patients and families that it helps some patients. We don't know who. Somewhat. We don't know how much. Sometimes there's some stabilization. Sometimes there's just better awareness, better involvement of the person without any improvement of their memory for some time. We don't know how long. So far from a medication that that will cure or arrest the disease. And the clinical approach also means treating vascular risk factors, treating diabetes, cholesterol, heart disease, etc., correcting sensory deficits, vision and audition, looking for and treating depression, screening for and treating sleep apnea, preventing falls, etc. By the way, sleep apnea is probably one of the most important things we can do. So as you see, there are many things that we can do, even though we don't have the best medication, but there are many things that we can do to manage and treat Alzheimer's and dementia, including lifestyle changes around improving sleep, diet, socialization, and cognitive engagement. And these are recommendations from the 5th Canadian Consensus Conference on the Diagnosis and Treatment of Dementia. But the question is, how do we make all this happen? What I've presented to you is sort of the clinical presentation, the pathway of the person who develops cognitive problems moving on to dementia. I presented to you what we need to do from a clinical point of view, but how do we make sure it gets done in our healthcare system? And that's why in 2007, the then Minister of Health, Couillard, asked me to chair and lead a task force to write the Quebec Alzheimer Plan, which was presented in May 2009. So why an Alzheimer plan? Well, because Alzheimer's is a complex disease, rapidly aging population. I don't have to tell anybody about that. By the way, there's some good news in that there's evidence that incidence of Alzheimer's disease may be declining. But one baby boomer in 5 will develop Alzheimer's disease in his or her lifetime. And this is becoming very important now, preparing for the advent of biomarkers and disease-modifying medications. And I'm going to speak to that in a few minutes, to that very important issue, which I'm sure you've read about, have become perhaps excited about, hopeful about, and I want to talk to you about that, and we can discuss it in the Q&A if you like. So the objectives of the Quebec Alzheimer Plan was to provide rapid access to assessment and management, and to also give personalized management with personalized access to primary care and community, as well as specialized services, through developing a trusting relationship between the patient and family and a credible clinician. We said it needs to be anchored in primary care, enable and empower the family medicine group primary care clinicians, mainly physician and nurse, but also now we have social workers and pharmacists in the family medicine groups, in collaboration and partnership, of course, with the specialty memory clinics and community services. By the way, why did we say anchored in primary care? I'm not going to get into that discussion very much, but I'm just going to say one thing. I co-founded and co-led the Jewish General Hospital Memory Clinic for many years. I still work there now. I like to say it was the best memory clinic in the world, but it would take 8 to 12 months to get in. So maybe the best in the world, but not very useful. And because the vast majority of what we were doing could have been done in primary care. And so we felt when we wrote the Quebec Alzheimer Plan is anchored in primary care, develop the capacity of primary care to detect, diagnose, and manage the vast majority of cases of dementia and Alzheimer's disease, and use the specialists for the complex cases, for the difficult diagnosis, difficult management, etc. And this is what it looks like in a schema. You can look at this. It's based on what we call the chronic disease model, a patient-centered approach and not a disease-centered. What do we mean by that? Well, people of Alzheimer's disease are mainly, not exclusively, older people, and older people have very, very, very often more than one chronic disease. And so we can't just treat one disease. We need to treat the person who has a combination of chronic diseases, who has a combination of psychosocial and socioeconomic setting. And we need to treat that person as a person, not as one disease or another. And so a partnership between the patient and caregiver on the one hand, and the family physician, nurse, social worker on the other hand. With the support as here, the specialized services like memory clinics and home-based services, community pharmacy, Alzheimer's Society, Alzheimer group, community partners, etc. That's the approach. And we developed, I'm just going to go through this, but not for you to really read, but just to say we developed a pathway and working to support the capacity of primary care to detect, diagnose, and manage, and then use specialty services when necessary. And so we've been working on the implementation of the Quebec Alzheimer Plan. We're in the third phase of the plan, of course, now with COVID, things are a bit more complicated and difficult to carry out. But what we found, we evaluated the plan, and what we found that the primary care, the GMs can develop their capacity to meet the needs of persons living with dementia, their caregivers, can develop their capacity to detect, diagnose, management, offering high quality care and using specialty care for complex cases. So it was feasible, and it was feasible to develop a person-centered interdisciplinary approach. We found that there was improved continuity of care, higher intensity of follow-up, improved quality of care, fewer but more appropriate specialist referrals, and a decrease of emergency room visits and hospitalization. So generally things moving in the right direction, we found in the evaluation of the implementation of the Quebec Alzheimer Plan, with areas of room for improvement, like the use of antipsychotics, the evaluation of caregiver needs, I keep coming back to that issue, and referral to community services. So now let's talk about what you're hearing about is biomarkers and disease-modifying medications. So what are biomarkers? What is a biomarker? A biomarker is something that provides detailed measures of abnormal changes in the brain, in the case of biomarkers for dementia. So it could help in the very early detection, even pre-symptomatic. You know, theoretically, we'd like to know, even before you develop any symptoms, we'd like to know if you have Alzheimer's disease and are going to become symptomatic, and then be able to, of course, with the condition that we can treat it before it becomes symptomatic. It can help in the diagnosis and can help in determining the type of dementia, and it can help predict and monitor progression. What are biomarkers? They include cognitive tests, memory testing, imaging, from very simple imaging like CT scan or MRI to very sophisticated, costly PET scanning, including also biomarkers in cerebral spinal fluid, known as CSF, and the most efficient would be blood biomarkers, a blood test. We don't have that. We now have some imaging biomarkers, some CSF biomarkers, and there are people who work on blood biomarkers, but this is starting to come together. And so if you look at this, diagram, just follow it. I'm going to click and you'll see. So this brown, you probably can't see it that well here, but this, can you see my arrow here? This is when clinical function is detected. This is when you're starting to have some changes in cognition, whoops. And even earlier, some changes in brain structure, and even potentially earlier, some changes in tau and in amyloid. So you can see the idea of the biomarkers, if you can detect it even before there are cognitive changes, and certainly even before clinical function. That's the ideal. But Alzheimer's disease is still very much a clinical diagnosis, and this came out of the the 5th Canadian conference. I was involved in 4 of them. So Alzheimer's is still clinical diagnosis, and a good clinician does not need biomarkers, and in fact, they're not real biomarkers available for the diagnosis. They're essentially still research tools. In very, very rare instances, they may help in determining a type of diagnosis, but essentially they're research tools. So essentially, we're still left with a clinical diagnosis of Alzheimer's disease. What about treatment? What about treatment? So we know that there are new disease-modifying therapies being developed with the aim of slowing down the progression, slowing down to the point, hopefully, of even stopping the progression. We could dream of even reversing the disease. And most usually these known as the monoclonal antibodies, directed either against the beta amyloid, the plaques, or the tau tangles. There are other types of therapies around anti-inflammation, neuroprotective, etc., but these are essentially the ones. So what you've heard about is aducanumab, or easy to say, the brand name Aduhelm. You know that it was approved by the FDA, the Federal Drug Authority in the States. Very, very controversial approval, where essentially the entire expert advisory panel told FDA, do not approve it, but the FDA did approve it. It has not yet been approved by any USA organization for reimbursement. Medicare is apparently going to give their decision this week. 90% of experts reject it, including Canadian experts who say this does not. I'll come. Why they explain why they reject it. I'll come back to in a second. And in fact, there have only been 100 prescriptions in the USA. It's already been rejected by European and Japanese authorities. The problem is, it may be biologically effective in removing amyloid, but was not and is not clinically effective on cognition and function. It doesn't seem to be any more clinically effective than the cholinesterase inhibitors, the Aricept, etc. With serious toxicity, serious potential for toxicity, extremely expensive, just for the infusion, and a very complex, expensive, high-tech biomarker, PET scan. Plus, you need 4 MRIs per year. Plus, it's an infusion where you have to go in once a month to get it. So, taken all together, but particularly because it hasn't not been shown to be clinically effective on cognition or function. So, for a medication that is not effective, there's serious issues of equity to access. Most places in Quebec and Canada do not have PET scans. So the cost is enormous. And even if the government said, you know, we'll cover 80% of $75,000 still leaves a lot to be covered by the individual. The burden of having to do all these testings, going back and forth, ethnic accessibility for ethnic populations, etc. You know, to use a bit of a caricature, it looks like it's going to be really effective or really accessible to wealthy people living very, very close to the MUHC or the CHUM. So if you live between, you know, several blocks of the MUHC and you're very wealthy, you're going to get the medication because you'll get the PET scan, etc. You have to pay for it. But if you live anywhere else in Montreal or outside of Montreal, you're not really going to get it. And it's a tremendous financial and resource burden to individuals and to the healthcare system. And billions of dollars will be diverted from other treatments that we are using for Alzheimer's disease and research that is necessary. So this is a picture from CNN. US lawmakers launch investigation FDA approval. So it's so controversial that they're now wondering what really happened and why did FDA approve it. So they're investigating FDA over this approval. In Canada, we had this commentary, and I have a lot more citations, basically by this group, including a person living with dementia, Mr. Marple. As physicians and researchers, we would not recommend its approval for use in Canada. The Institute for Clinical and Economic Review in the States said, in summary, we judge, and I think this is the best quotation I can find. In summary, we judge that the evidence is insufficient to conclude that the clinical benefits of aducanumab outweigh its harms, or indeed that it reduces progression of Alzheimer's disease. That, I think, summarizes a pretty damning assessment of this medication. But there is good news out of this disappointment. There is good news, and the good news is there are other disease-modifying medications in the pipeline. We'll have to see, but what we really need is, number one, a medication that's going to be effective in delaying or reversing disease with a clear impact on cognition and function. We need simple biomarkers. It can't be having a PET scan because there'll never be, we can't start putting PET scans in every street corner in the country. We're going to need simple biomarkers. We need a simple delivery, a pill rather than infusion. We need minimal toxicity, and we need reasonable pricing. This is a tall order, but I think this is the direction we need to think about in terms of new medications coming down the pipeline. Is it going to happen? It will. Is it going to be this year, next year, in 5 years? It's hard to say. The challenge is also, is our healthcare system going to be ready for these complex medications for a complex disease like Alzheimer's disease and dementia? Is the solution, as many have said, adding more neurologists and more PET scans? I don't think so. I don't think that's going to be a solution. It won't work. But I think we can build on the implementation, for example, in Quebec and other parts of the country, but in Quebec, on Quebec Alzheimer Plan, anchored in primary care with support of specialty and community care, with good point of care testing and treatment, and in a shared care for the more complex cases between primary care and specialty care. So in conclusion, the detection and diagnosis of Alzheimer's disease is still clinical. Treatment and management includes being inclusive, dignity, respect, understanding and optimizing the participation of the person living with dementia. We have symptomatic medication, not impact is marginal, but we need to use them. Lifestyle and risk medication, for example, treating diabetes, hypertension, cholesterol, lifestyle, remaining active, physically, socially, good nutrition, and caring for and supporting caregivers. The implementation of the Quebec Alzheimer Plan has greatly improved the capacity of our healthcare system to manage Alzheimer's disease. And as of today, there are no effective biomarkers or medication that can halt the disease. However, there's real progress. And we need to continue to invest and support research. So these are just some acknowledgements of people I work with. Howard Churtko, who gave me some advice and a few slides for this talk. Our ROSA research team. Caroline Boudreau, who's the coordinator from the Ministry of Health, who's doing excellent work, and all the stakeholder partners that we work with. This is going, there's some useful links if you want to look at the Quebec Alzheimer Plan. If you want to, people want to look at some of the policy lessons that we drew on the implementation of the Quebec Alzheimer Plan, the interdisciplinary pathways. I think you're going to have access to these slides. And this is the report that we did to the Public Health Agency of Canada to inform them on their preparation of the Canadian Dementia Strategy. And this is a link to the Canadian Dementia Strategy for those who want to look at that as well. So I've come to the end, and I think I've kept my promise in leaving lots of time for discussion with you, and I hope I've stimulated some thinking and questions on your part.
Absolutely. Thank you, Dr. Bergman. I think, you know, I've been working in this field for many, many years, and I see the progress, and I see, you know, I really appreciate the focus on dignity and respect for people living with dementia, as well as their family, and, you know, the strain that it takes on the healthcare system, and will continue to do so, because a lot of the families that we support can get frustrated, and we really try to focus on how to advocate, how to access services, and sometimes we have to kind of tell them to go around in a different way. So that's I know that a lot of families will appreciate, especially the insight on this new medication that you spoke about and so forth. So I'm going to ask Nin, our outreach coordinator, to look at the Q&A, and I'll also help out with that. So I'm sorry, it's going to be just you and I talking, but hopefully please use the Q&A function. We have about 15-20 minutes for questions, and we'll try to combine them if need be. Okay, go ahead, Nin.
Okay, thank you. So Louise asked a question. So you've touched a little bit on the Alzheimer plan that was started in 2009. How do you see this implementation going in the near future?
So thanks for that question. The Alzheimer plan was the report that I did, and the plan that was proposed was presented to and accepted by the minister in 2009. The implementation began in 2011 with an investment of $5 million per year. And there was a first phase, and it was very interesting. The first phase was basically in 40 family medicine groups in Montreal, Quebec City, urban, rural, suburban, etc., remote, starting what we called implementation projects. So to learn about the implementation before generalizing everywhere. And there was evaluation. The second phase, which began in 2017 or so, was then the beginning of generalization to all the other areas in Quebec. And now this third phase, and we're stuck because of COVID, is going to put the emphasis on two things: transitions, which is always a very difficult. So transition from community to hospital, from hospital back to community, from community to assisted living, etc. That whole issue of transitions where people get lost in between. And the other is behavioral manifestations. Because what is perhaps the most difficult for everybody, particularly for the person living with dementia, for the family, but also for all the clinicians and the healthcare system, is behavioral manifestations. And so we're doing a lot of work on that now to strengthen the capacity to deal with behavior manifestations, which have to be often dealt with very rapidly. When we're assessing cognition, we have time. When there's an issue of behavior manifestation, something has to be done rapidly, and I'm dealing with a case now, and it's extremely trying for the family. And we want to avoid, use of emergency room when it's not necessary. So that's where we are in the implementation of the plan. I must say, the ministry has been exemplary in stimulating, promoting, helping, supporting the implementation of the plan.
Thank you. Dorit, I do see your hand, but I'm going by whoever has their questions first, so I'll get back to you. Another person asked, can dementia in Parkinson's disease manifest itself the same as in Alzheimer's?
Yes, and it can, but it may manifest itself a little bit differently as well. So it'll never take on a typical pathway of Alzheimer's disease because you have the complication of the Parkinson at the same time, and so it may also mimic Lewy body disease. So it's a bit more complicated, and the different factors have to be sorted out.
Okay, do you want me? I will ask a question about sleep apnea. Sleep apnea is, as you mentioned, is an important factor to consider with diagnosis and so forth. Can you just discuss this a little further? Because is there a direct link in your 50s and 60s directly associated with the increased risk of developing Alzheimer's disease or dementia? Is using the CPAP machine a way to reduce that risk or the rate of cognitive decline? I think more and more people I know are on the CPAP machine, and any insight to sleep apnea would be appreciated.
So, if I just make a little joke to start with, you're replacing the snore, you're replacing disturbing your spouse with the snoring by disturbing your spouse with the noise on the CPAP machine. But so I'm not aware of a direct impact of sleep apnea on cognition as such. There may be, but I'm not aware. It's probably an indirect through the cardiometabolic pathway. And so people with sleep apnea have more risk for atherosclerosis, etc. And that's probably the pathway. It would be logical to think that there is a direct impact, because if you're reducing the oxygen to the brain because of the apnea, then you're giving these constant insults, if I'm to use that expression, to the brain. I think if there's one thing that somebody can do, well, if you have sleep apnea in your 40s or 50s, whenever, it makes sense to treat it with CPAP. We know that there's a lot of adverse outcomes because of sleep apnea. It makes sense. Forget about cognition, just makes sense from every point of view. If unfortunately you develop dementia, MCI, and you're assessed for sleep apnea, then yes, probably one of the most important things you can do, although we don't have a lot of good data, is to treat the sleep apnea with CPAP.
Thank you.
Jorrit, I just allow you to speak, so you can go ahead and ask your question.
Oh, okay. Sorry, I just typed it in. I was asking, thank you, doctor, for the presentation. I wanted to ask you, given the state, and this might be a larger question, but given the state of the availability of doctors in the province and the fact that the average person can't find a GP, I wanted to know how you believe that the GMFs are prepared to become the first point of contact to see all of these patients, to do the evaluations and diagnose, etc. Thank you.
So that's obviously a very, very good question. We have to solve this problem of accessibility to primary care. Dementia, no dementia, we have to solve that problem. So if we say, okay, dementia is not anchored in primary, it's going to be anchored in specialty care, there's even going to be less accessibility, because there's very, very few specialists who are interested in dementia care. There's the geriatricians, most of them are. Neurologists, only some of them are. And psychiatrists, even less, only a small minority are. So do you make the decision specialty care because there's not enough accessibility to primary care? That would be a mistake, because there's even less accessibility. There will be even less accessibility to specialty care, to specialists interested. And as I said, the joke, which is not really a joke, about the memory clinic, which it's easier to get into now, but the best in the world, but take 8 to 12 months to get in. And by that time, my daughter, who's in marketing communication, can probably make the diagnosis. So we have to solve this problem of accessibility, and that's another long discussion. There are no easy answers. I happen to think it's solvable, but it's a complex issue that we need to work on. I published an op-ed in the Presse Plus about 6 or 8 weeks ago on that issue.
Thank you.
Okay, thank you, Dr. Bergman. So,
but just let me add, the process of taking care of people with dementia in primary care is not just a doctor. The nurses and social workers and pharmacists in the GMFs are playing an increasingly important role. And in fact, in the Alzheimer plan and in the clinical pathways that we developed in implementing the plan, there's a major role for nurses. So it's going to be an interdisciplinary team approach, and that'll help develop the capacity.
Absolutely. Very necessary. A question about medication. We have, can you just mute Dorita? So a question about medication. So we know people on Aricept wondering if it's an effective drug, but are there any new medications down the pipeline taking a different approach, not simply addressing the plaques and the tangles? There's some research someone has mentioned in the US, extending I might mispronounce it, I'm sorry, telomeres, and they wonder whether or not any new angle will be looked at in Canada.
So I'm not the best person to ask that question, but yes. So, you know, the problem with the plaques and looking at the plaques and tangles is the chicken and the egg. So, for example, in removing the amyloid plaques, are you in fact treating the disease or treating a manifestation of the disease? And that's the problem with the aducanumab or Aduhelm. So you're right in asking this question. So people are looking at other avenues. So inflammation, and there were trials which really didn't succeed of using anti-inflammatory, and also now infection, which people are starting to look at. So yes, there's a whole array of therapeutic targets that people are looking at. Neurodegenerative diseases are very complex diseases. You know, in Parkinson's, we actually identified the cause of Parkinson, but in spite of that, we still don't have a medication for the cure. So it's a complicated disease, and it may be that Alzheimer's disease is really Alzheimer's diseases. And it may be that certain medications will be effective for certain people and not for others. And so there, the use of biomarkers in determining for whom it would be effective is very important.
Okay, so there are a couple of questions asking if there's any genetic link between dementia and Alzheimer's disease.
So
Sorry,
I think
genetic link with dementia and Alzheimer's disease.
yeah. So yes, there is, and in a very, very small, thankfully, percentage, there's a very direct link. As I say, it's a very, 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 very small and thankfully small percentage of cases. In a much larger percent of cases, there is a hereditary genetic component. ApoE4, for example, was one of the that is mentioned often. Yet we know that it may have an influence and may influence 10, 15%. But I want to emphasize this, that there's a lot of positive factors that outweigh that. So for example, I sometimes have a patient that come to see me. I'm worried my mother, my aunt, my grandmother at 85 developed Alzheimer's disease. I said, yeah, that sort of increased your risk, but also in your cohort, you have a university education or a college education. In your cohort, we're treating much earlier hypertension and diabetes. You're eating better than the previous cohort. You're exercising more. So there's all sorts of other factors that play in. So we can't just look, again, for a small group, there's a very strong genetic component, very, very small group. But for others, and that's the importance of lifestyle, two things, lifestyle. So wear a helmet, by the way. when you ski and when you bike. Get your kids to wear helmets. You want to protect. Stay in school as long as you can.
That means they have to have school happening in person, right?
So, no, we didn't say in person. Yes. Aren't we all waiting for that moment? But luckily we have grandparents like me and my wife that contribute. So lifestyle changes, exercise, socially active, treating diabetes, etc. So in other words, don't be nihilistic. There's a lot of things we can do, even if your mother had Alzheimer's disease, as my mother did at the age of 93. There's a lot we can do. And there's a lot we are doing because our cohort is different. We're doing things our parents never worried about, about how much fat they were eating, how much salt they were eating, or how much exercise they were getting.
Thank you. There was actually a question about diet, so thank you for touching on that. You talked about one of the hardest things is some of the behaviors that manifest with Alzheimer's. And a lot of families have a little somewhat challenging time with sundowning. So later in the day, when the persons get increasingly tired, increasing agitation, anxiety, can you touch a little bit about sundowning and maybe some medications, pros and cons?
Yeah. So sundowning and other behavior manifestations are important issues. We like to avoid using medications unless we really have to, because there's always the good part of the medication, there's always the bad part of the medication. And many of the studies show that medication doesn't help in many instances unless there's a targeted reason, number one. Number two, we need to look at do an evaluation. Is there some sort of underlying medical problem that is creating, for example, the agitation? Is the person developing pain at the end of the day because they've been walking around a lot? The medication then would be, something simple like acetaminophen, Adderall, or Tylenol, and not some medication for behavior, if you see what I mean. So understand, is there anything going on from a medical point of view? The third, is there anything going on from an environmental point of view? Is at the end of the day, people are coming home after work. It's a more agitated environment. People, the children are coming home, depending on the age. There are things going on that was quiet during the day. So you want to look at certain environmental issues that you can think of, that you can modify. So there's a lot we can do for all the mitigate any of the issues that may be stimulating the sundowning. And after that, then it's a question of, do you want to use medication? What type of medication? I don't want to get into that now because I don't want to mention any medication, because what might work in one person might not work another, etc.
Thank you. I think we have time for one last question. Lorna asks, I read that when people do not take care of their dental conditions like deteriorating gums, etc., some adverse substances can migrate down to the heart and affect it. I wonder if these adverse substances can migrate up to the brain and affect it too.
So I'm not sure they migrate to the heart if you have valvular problems. The link between, first of all, bad dentition is not good at all, because you're not going to eat as much, you're not going to eat well, you're going to be in pain. So there's a lot of reasons to treat bad dentition, number one. Number two, is it creating, the microbiome, is it creating some sort of adverse bacterial environment in the gut, which is then explaining some of the, and we're starting to understand that some of inflammation in the body and the brain, that's another issue. Whatever it is, it's probably not a direct, bacteria going right to the brain. It's an indirect, but whatever the issue is, there's lots and lots of reasons to have good dentition, to have good mouth hygiene, which will lead to
Absolutely.
better quality of life for everybody.
Absolutely. Dr. Bergman, I just want to thank you. There was a lot of comments in the Q&A about getting better training for professionals working obviously in long-term care facilities, just in the community, working for healthcare agencies, and also increased funding for community services. So hopefully those are some of the things to consider when working so diligently on your the Quebec Alzheimer's plan. So thank you for that. Tomorrow's lecture is going to be again at 11 o'clock. Dr. Wendy Chu will be presenting on the D word, demystifying dementias. Some people had a little bit of difficulty logging in today and they missed part of the lecture. Other people couldn't get on. Rest assured, we will have this lecture recorded and put on our YouTube, and you will get information if you had registered. AGI, again, provides services for everyone living with dementia. If you want to find out more information about our programs, please go to our website or give us a call, and we will happily support you in this caregiving venture. Okay. Thank you very much, Dr. Bergman. We really appreciate it.
My pleasure. Okay.
Have
Bye-bye. Bye-bye, everybody.
Have a great day.
Bye-bye.
Bye-bye.